actually discussing the ACTH use. So actually it can be used in anti-respiratory disease where ACTH release is low, but it is actually inconvenient and expensive. So still the treatment of ACTH deficiency also we are using corticosteroid mainly, and side effects and concentration is similar to that of the steroids. Then being a foreign protein, ACTH may produce anaphylactic reaction. So now let's discuss the corticosteroids in detail. And corticosteroid, as I have discussed, that it is essential for the life survival and it helps in the adaptation of the changing environment. So it is actually organ of par excellence and it is essential for our normal homeostasis, maintaining normal homeostasis. And there are different parts of the adrenal cortex. So adrenal medulla synthesizes adrenaline or epinephrine, but adrenal cortex synthesizes corticosteroids, and among them there are three parts on the adrenal cortex also. One is called zona glomerulosa, that synthesizes aldosterone, that is an mineralocorticoid, and zona fasciculata synthesizes glucocorticoids, mostly hydrocortisone, that is synthesized, and zona reticulata that synthesizes sex steroids. Okay, so there is regulatory control from the hypothalamus as well as pituitary. Already you have discussed that hypothalamus releases CRH and pituitary releases ACTH, that increases the synthesis of this aldosterone, glucocorticoid and sex steroid from the three zones. So remember, zona glomerulosa synthesizes aldosterone, fasciculata releases glucocorticoid, and reticulata synthesizes sex steroids. So these are from the outer to inward aspect of the cortex. So glomerulosa, fasciculata, reticularis, GFR. Okay, GFR synthesizes AGS. So GFR, if you remember, then AGS, aldosterone, glucocorticoid and sex steroids. Okay, GFR synthesizes AGS. How to remember it easily. And remember, there is a circadian rhythm in the corticosteroid release, so mainly glucocorticoid release. So it has been seen that in the midnight there is a sharp fall, but in morning 8 AM there is a sharp rise in the glucocorticoid release. That's why while we are detecting the corticosteroid deficiency, like adrenal insufficiency, then we are measuring the blood at the 8 AM to see what is the peak during that, because during that peak hour what is the level. If it is low, then we can confirm that it is actually adrenal insufficiency. And so in midnight it is low, but in 8 AM it is high. Okay, but so when there is corticosteroid excess, suppose in Cushing syndrome, then to detect the Cushing syndrome, what we do? Normally we do corticosteroid suppression test, that is also called dexamethasone suppression test. So dexamethasone is given, and by its negative feedback it will decrease the ACTH release and decrease the endogenous steroid synthesis from the adrenal cortex. So when we are giving exogenous steroid, that is actually decreasing the synthesis of the endogenous steroid, and that is measured. If it is measured during 8 AM, then it will be low. Okay, that you can detect the Cushing syndrome or corticosteroid excess, whether corticosteroid synthesis is excess or not. That is actually decreased by the exogenous corticosteroid. So we can detect the actual level if we measure the corticosteroid level at 8 AM. Okay, 8 AM cortisol level. That's why it's a very important test to detect the Cushing syndrome. So this is the synthetic pathway of the corticosteroid. So this is a long pathway, and as glucocorticoid, mineralocorticoid, sex steroids all are synthesized from this. So there are multiple enzymes are involved, and remember once again, this is the primary molecule is cholesterol, and cholesterol under influence of ACTH that will divert the synthesis of the glucocorticoid and mineralocorticoid. So cholesterol first step is pregnenolone. After that, pregnenolone can be from pregnenolone there are two pathways. One is 17-hydroxypregnenolone, which is synthesizing the dehydroepiandrosterone. That means it is a sex steroid, and on the other hand there is a synthesis of the progesterone from the pregnenolone, and this progesterone will synthesize androstenedione and estrone. So estrone as well as dehydroepiandrosterone, that is androgen, and estrone is a precursor molecule of the estriol. So there is synthesized from the cholesterol, as well as after progesterone there is synthesis of this 11-deoxycorticosterone, then 18-hydroxycorticosterone, and ultimately aldosterone. And after that, and also in a side way, 17-hydroxyprogesterone by 21-beta-hydroxylase that synthesizes 11-deoxycortisol, and 11-beta-hydroxylase enzyme converts 11-deoxycortisol to cortisol. So aldosterone is a mineralocorticoid, which balance the fluid and mineral status of our body, and cortisol mainly influences the metabolism of glucose as well as protein, fat, as well as play important role in the inflammation, anti-inflammation. Okay, androstenedione is a androgen and estrogen is an from estrogen there is synthesis of the estradiol. So pregnenolone, cholesterol, then pregnenolone and progesterone. So these are the pathway by which we can have all these mineralocorticoid and glucocorticoid, aldosterone, cortisol are mineralocorticoid and glucocorticoid respectively. Testosterone is synthesized from the androstenedione and estradiol is synthesized from the estrone. Okay. So classification of adrenocorticosteroid, there can be natural and synthetic. I have discussed that natural glucocorticoid is hydrocortisone and natural mineralocorticoid is aldosterone. Okay. So and among the synthetic glucocorticoids, there are prednisolone, methylprednisolone, triamcinolone, beta-methadone, dexamethasone. There are multiple ones. And mineralocorticoids, synthetic is fludrocortisone. So the normal rate of secretion of the two principal corticosteroids in man are in hydrocortisone. They are synthesized 10 to 12 milligram daily, and nearly half is synthesized in the morning hour. Aldosterone production is 0.125 milligram daily. So remember, this hydrocortisone, aldosterone are natural glucocorticoid and mineralocorticoid respectively. Rest are synthetic. And there is a classification according to their duration of action. So natural or mineralocorticoid is aldosterone and glucocorticoid is hydrocortisone. Synthetic, it can be divided into three parts: short acting, intermediate acting, long acting. Short acting is hydrocortisone. So hydrocortisone both endogenous and as well as it can be administered exogenously. That's why it is short acting. It is classified as a short acting synthetic. So hydrocortisone, cortisone are short acting. Intermediate acting is prednisolone, triamcinolone, and long acting is dexamethasone, beta-methadone. So 36 to 72 hours is the long acting dexamethasone, beta-methadone. And if we remember the asthma, their inhalation corticosteroids are used, and the examples are fluticasone, beclomethasone, budesonide, etc. Topical corticosteroid that is used in different dermatological disorders like clobetasol, mometasone, etc. And mineralocorticoid without any glucocorticoid activity, that is fludrocortisone. So these are the different synthetic corticosteroid: short acting, intermediate acting, and long acting. Dexamethasone is long acting, short acting is hydrocortisone, intermediate acting prednisolone is intermediate acting. Inhalation is fluticasone, budesonide. Topical, you have clobetasol, mometasone, and mineralocorticoid activity is without any glucocorticoid activity is shown by the fludrocortisone. And this is in short the mechanism of action. So glucocorticoid receptors present in the cytoplasm, and when the ligand is bound to them, then they is transferred to the nucleus. So steroid is free from cytoplasmic protein receptor. Steroid receptor complex is formed, which is then transferred to the nucleus, and they ultimately influence the modulation of the gene. There is increased transcription of few proteins, which mainly regulates the fluid status, mainly regulates the mineral handling, also regulates the inflammation. So there are also decrease in, so it has been seen that glucocorticoid actually, by this modulation of gene, they actually decrease the production of the inflammatory proteins and increase the production of the anti-inflammatory proteins. So there is anti-inflammation. So this is the picture in nucleus. There is the influence the transcription, translation of mRNA, and there are mediator proteins which exert different response of the glucocorticoids. So steroid receptor is a cementary amino acid domain. It has a zinc finger motif, and this is called steroid response element. That means the part of the gene which is modulated by the steroid, and there are some non-genomic and genomic effects. So they regulate the expression of the responsive genes and changes the level of the adaptive proteins. The action manifests after several hours. So as they this is active on the they act by the modulation of the gene and modulation of the transcription process. So that takes a long time. So that's why in asthma or in emergency situation, corticosteroids are given, but time takes some hours to act. Okay. Membrane receptors related effect is immediate. So that is, the receptor needs to transfer to nucleus, the action takes some time, whereas the receptors which are present in the membrane, and they are active immediately, but steroid is not so. Okay. So aldosterone increases the membrane protein level. That is an additional action. So aldosterone also acts by the same mechanism, but they increase the membrane protein synthesis, which will actually handle the sodium and potassium. The aldosterone increase the sodium absorption and potassium excretion. Next, so this is the mechanism of action, and there are some metabolic actions we have to know. So metabolic actions, once again I am recapitulating that it is mainly a glucocorticoid function. So mineral and water handling is action of mineralocorticoid, and metabolism and anti-inflammatory action, that is action of the glucocorticoid mainly. Okay. So metabolic action, the carbohydrates, they actually increase the glucose deposition in the liver as well as increase the glucose production from the liver. So they protect glucose dependent tissues, brain and heart from starvation. There is some anti-insulin effect, that's why they increase the gluconeogenesis and neoglucogenesis. Okay. Gluconeogenesis and glycogenolysis, that is increased by the corticosteroid. So when there is hypoglycemia is a stress, so corticosteroid help in the excess production of the glucose from the liver so that hypoglycemia can be corrected rapidly. Similarly, when there is hypotension, corticosteroid takes upper hand and they increase the synthesis of the mineralocorticoid, which will maintain the blood pressure as well as prevent the further excretion of the water. So thus corticosteroids are helpful in all the stressful response, and it increases the gluconeogenesis, increase the glycogenolysis, also increase the reduce the glucose uptake and utilization. Okay, so there is more blood in the glucose, more glucose in the blood. That's why there is hyperglycemia, and that's why steroid induces diabetes mellitus in the susceptible person. So it has been found that often a patient after taking corticosteroid in high dose for few days, their blood glucose is elevated, but that we should not diagnose diabetes mellitus on those report only. We should wait for a few days, and actually we can measure the HbA1c level. If HbA1c is high, then we are confirmed that it is diabetes, but if HbA1c is low, then we have to actually recheck the fasting and postprandial blood glucose after a few days, and then if it is most of the time corticosteroid induced diabetes mellitus, that is reversible, and most often patients do not require any anti-diabetic medicine. And lipid, there is increased lipolysis and there is excess free fatty acid, and ultimately that will increase the fat generation. There is weight gain, there is Cushingoid, so it is also called Cushingoid habitus. Okay, so corticosteroid, they promote lipolysis due to glucagon as well as growth hormone, and remember their corticosteroid has some action that is called permissive action. Permissive action means they are not acting directly, but they are helping the action of the other hormones. So similarly, the promotion of the lipolysis here is also dependent on the glucagon actually. Glucagon, adrenaline, thyroxine all help in their action of this inhibition of the promote lipolysis. And fat depots in different areas of the body respond differently. There is redistribution of the body fat, and subcutaneous tissue over extremities loses fat, which is deposited over face. So there is loss of the extremity fat, which is deposited over face actually. So there is redistribution of fat. There is excess fat deposition on the face, neck, shoulder. That's why it is called moon face or buffalo hump. Over the neck, there is the accumulation of fat, that is called buffalo hump. And peripheral adipocytes are less sensitive to insulin and more sensitive to corticosteroid facilitated lipolytic action. That's why breakdown of fat predominates. Whereas truncal adipocytes respond mainly to the raised insulin level caused by glucocorticoid induced hyperglycemia. And also in protein, there is negative androgen balance, so there is catabolic action on the protein. Okay, so this is the metabolic action: carbohydrate, lipid, and proteins. This is the action of the glucocorticoids. On the other hand, mineralocorticoids, they act on the discharge tubule and collecting tube duct, and they retain sodium and promote potassium and hydrogen excretion. Okay, so they retain sodium, mineralocorticoid, mainly aldosterone, which is a naturally acting mineralocorticoid, and they promote sodium, potassium, and hydrogen excretion. Fludrocortisone, on the other hand, there is a synthetic potent mineralocorticoid without any glucocortic activity. That's why they are used in the severe orthostatic hypotension. That means the postural hypotension, where patient's blood pressure is falling significantly when patient is in standing posture, but its blood pressure remains normal in the supine posture. So that indicates actually severe deficiency of the mineralocorticoid. We use fludrocortisone in the postural hypotension. And also mineralocorticoid and glucocorticoid, they reduce calcium level, there is increased excretion of the calcium, there is reduced absorption, and so their action is actually opposite to the vitamin D. They also inhibit the they actually increase the osteoclastic bone resorption. That's why there is osteoporosis. Okay, so they reduce the blood calcium level, as well as they have some anti-vitamin D action, and there is chance of osteoporosis with this corticosteroid. Next, cardiovascular function. There is increased blood pressure because of this fluid and water retention. There is increased blood pressure. There is promotion of the atherosclerosis. There is chance of stroke, hypertensive cardiomyopathy. They enhance the vascular reactivity to vasoactive substances. So once again, this is the permissive action. The actions of the adrenaline, norepinephrine, their vascular response. That means the vasoconstrictive effect of the adrenaline, noradrenaline, they are enhanced by the corticosteroid, and they also actually increase the cardiac fibrosis. Mainly, aldosterone is responsible for the cardiac fibrosis. That's why in heart failure, if you remember that there is significant amount of aldosterone, and that will actually cause the cardiac remodeling, and that is due to accumulation of this aldosterone. There is increased expression of the adenosine receptor in the vascular wall, and so we have discussed that corticosteroid actually increases transcription of the different proteins, and one of them proteins is receptor of this adrenaline. So beta 2 receptor of the adrenaline, their synthesis is increased by the corticosteroid, and that's why in asthma, if you remember, asthma in corticosteroid and beta agonists are given simultaneously to have synergistic effect, because corticosteroid actually help in the further synthesis of the beta receptor. That's why beta 2 agonists are more effective if we combine them with corticosteroid. Hyperaldosteronism, there is decreased BP and vascular collapse. So when aldosterone production is less, there is decreased BP and vascular collapse. Lymphocyte action, that is the important aspect that is utilized in treatment of the different inflammatory disease. There is increased apoptosis of the lymphoid cells, and actions of the interleukin 1, 2, 3, 6, TNF alpha, also GM-CSF, there is inhibited. Inhibit the phospholipase A2 and COX-2. There is phospholipase A2, if you remember, that is the initial step in the synthesis of the prostaglandin and leukotriene. Phospholipase A2, that actually help in the synthesis of the arachidonic acid from the membrane phospholipids. So membrane phospholipids to arachidonic acid, there is this enzyme is active, phospholipase A2. From arachidonic acid, there is two pathways. Prostaglandin pathway is called COX pathway, cycloxanil pathway, and leukotriene pathway is called LOX pathway. So if we inhibit the phospholipase A2, then arachidonic acid production is less, inhibited. Thus prostaglandin, leukotriene, all the mediators of the inflammation is inhibited. Thus it is very useful step to inhibit this phospholipase A2 if we want anti-inflammatory effect, as well as it inhibits COX-2. There is decreased production of the cytokines, and that all of these are responsible for this. As they increase the apoptosis, these are utilized in the treatment of the Hodgkin lymphoma, inextricably linked to suppression of the inflammation. So all these steps actually help in the suppression of the inflammation, and as well as immunosuppressive effects. So there is decreased risk of vasoactive and chemoattractive factors. They reduce the extravasation of the leukocytes. And in anti-inflammatory process, they suppress both early and late phase, affect pro-inflammatory cytokines generation. So I mentioned in the transcription process, the corticosteroid actually help in the synthesis of some anti-inflammatory proteins, but cytokines, but also they decrease the transcription of different pro-inflammatory cytokines, and ultimately they inhibit the phospholipase A2. Also, as a result, there is decreased production of all the prostaglandins, also decreased production of the interleukin 1, 6, TNF alpha, and they inhibit the fibroblast proliferation, they reduce the fibrosis, and they reduce the collagenous enzymatic activity. So all these are responsible for the anti-inflammatory action of the corticosteroid. So on skeletal muscle and blood, what is the action? There is steroid myopathy with high dose. There is enhancement of the lymphocyte apoptosis. They stimulate the erythropoietin secretion. They diminish destruction of the erythrocytes in the autoimmune hemolytic anemia, and they cause polycythemia in the Cushing syndrome. So Cushing syndrome is actually corticosteroid excess. So once again, this is the mechanism of action of the corticosteroid in detail. So most hydrophobic steroids are bound to plasmaprotein carriers. Only unbound hormones can diffuse into the target cell. So from the corticosteroid, after synthesis from the adrenal cortex, they are released in the blood, and from the blood, the unbound part diffuses into the cell, and corticosteroid hormone receptors are present in the cytoplasm, and after receptors are bound to the steroids, they are translocated to the nucleus. And the receptor hormone complex binds to DNA and activates or represses one or more genes. So once again, there is a role of co-activator and co-repressor. Co-activator means the agents which will help in the corticosteroid function, and repressor means when corticosteroids are inactive, when steroids are not there, the repressor parts actually suppresses the transcription of few genes whose transcription will be enhanced by the corticosteroid later. Okay, so after the corticosteroids come to the nucleus, there is activated gene creates new mRNA that moves back to the new cytoplasm. Translation produces new proteins for cell process. Also, there is inhibition of the translation of few proteins. Mostly, inflammatory protein production is decreased. And some steroid hormone also bind to the membrane receptor that use second messenger system to create rapid cellular response. So some steroid hormones also bind to the membrane receptors, and they use different second messenger system, and that creates actually the rapid cellular response. So some steroid response are rapid, that is due to second messenger system, and actually the nuclear function that will take some time. And this is stress and adrenal glands short-term stress response. You see that there is increased blood glucose due to glycogenolysis, increased blood pressure because of salt and water retention. There is increased metabolic rate, and long-term response is actually there is sodium ions and water is preserved. That's why there is increased blood volume, increased blood pressure, and conversion of the proteins and fats to glucose because of this new glucogenesis, and ultimately immune system is suppressed because of this long-term steroid effect. So we have discussed once again carbohydrate and protein metabolism. There is increased gluconeogenesis, and there is decreased peripheral utilization of glucose. Glycogen deposition in the liver are also excess. So there is activation of the hepatic glycogen synthesis. So it is ironic that glycogenesis as well as glycogenolysis both are increased by this corticosteroid. Actually, they are used for stress response. So corticosteroid help in the reduction synthesis of the store of the glucose in the liver, and when needed they will liberate them also. Okay, so that's why it is very useful for the handling the stress response. They increase the glucose deposition in the liver, as well as when needed they will increase the glycogenolysis to increase the blood glucose level. And action in lipid metabolism, there is distribution of fat, we have discussed already. Aldosterone is more important, act on the distal tubule and collecting duct of kidney. There is increased sodium reabsorption, there is increased urinary excretion of potassium and hydrogen, and in addiction disease, that means there is a significant adrenocortical deficiency. So there is glucocorticoid synthesis is much low. Addiction disease, what is the effect? There is sodium loss. So glucocorticoids conserve sodium. In addiction disease, there is decreased sodium because most of the sodium are lost. There is decrease in the extracellular fluid volume. Cellular hydration is increased, and there is decrease in the blood pressure, decrease in the blood volume. So ultimately there can be circulatory collapse, renal failure, and death. And in cardiovascular system, what is the effect? They maintain the tone of the arterioles, they increase the myocardial contractility, but there is decrease in the capillary permeability. So mineralocorticoid induced hypertension is there. Hypertension is not so much predominant, but actually salt and water retention is more predominant. If it is in the long run, they actually increase the blood volume, and that can increase the hypertension. There is no direct vasoconstrictive effect of the corticosteroid, but actually they have the permissive action of adrenaline to increase their vasoconstriction effect. So that's why all of them actually cause the hypertension, but there is a delayed effect. Mainly they increase the blood volume initially, and salt water retention is initially. So sodium sensitizes the blood vessel to the action of the catecholamines and angiotensin. Skeletal muscle, the corticosteroid needed for maintaining the normal function of skeletal muscle. Addiction disease, there is weakness and fatigue, that is due to inadequacy of the circulatory system, and prolonged use can cause steroid myopathy. Immunosuppressive effect we have discussed, and at high dose it interferes with all steps of immunological response. So when it is needed, so it causes greater suppression of the cell-mediated immunity, and there is gas rejection and delayed hypersensitivity. So that's why it is very useful in the treatment of the graft rejection. So in graft rejection, when after organ transplant, recipient cannot tolerate the organ of the other patients, because often there is an immunological mismatch. So corticosteroids are very helpful to prevent the graft rejection and delayed hypersensitivity, because they decrease this inflammation. and there is decreased antigen expression from the grafted tissue, there is delay in the revascularization, there is decreased sensitization of the T lymphocyte receptor. Hello. কটা বাজে এখন? কটা বাজে? হ্যাঁ, তাহলে এই দেড়টায় বেরোবো, দেড়টা। সেই বেরোনো যায়, অসুবিধা নেই। So this suppress all types of hypersensitivity and allergic phenomenon, and this is the actions mainly both anti-inflammatory action and anti-immunosuppressive action both are dependent on their action on the lymphocytes. So there is decreased leukocyte accumulation, decreased monocyte, there is monocytopenia, eosinopenia, decreased complement components, and also these are responsible for the anti-inflammatory effects. And immunosuppressive effect is there is decreased lymphocyte and monocyte function, lymphocytopenia, monocytopenia, and there is decreased complement level. So both of them actually contribute in the immunosuppressive as well as anti-inflammatory purpose of the corticosteroid. That is actually the major use of the corticosteroid. Corticosteroids are mainly used for some inflammatory disease and some immunological disease as immunosuppressive agent and anti-inflammatory agent. Calcium metabolism we have discussed that it decreases the intestinal absorption as well as increase the renal excretion. That's why there is decrease in the blood calcium level, and also there is more osteoclastic function. That's why there is increased bone resorption, and that will cause osteoporosis. So corticosteroid induced osteoporosis is very common, and we have to treat it with bisphosphonate group of drug that will be discussed during calcium class. So corticosteroid induced osteoporosis is very common. The long-term corticosteroid therapy should not be given in the elderly female, especially because of risk of this osteoporosis. In asthma, we have discussed the role of the corticosteroid. They are used as the anti-inflammatory action as well, because asthma is an inflammatory disease. There is increased release of the mucus as well as bronchoconstriction. All are due to these excess inflammatory mediators activity. So corticosteroid, by influencing the gene transcription, they actually decrease the inflammation in the bronchi. That's why they are used as in asthma. And corticosteroid help in the production of the beta-2 receptor more. That's why beta-2 receptor and corticosteroid are given together to have synergistic activity, but they are not bronchodilator. For bronchodilator action, we need beta agonists. Okay, so they are not bronchodilator, but they are most potent and most effective anti-inflammatory. But the effect is not seen immediately. There is delay in the 6 or more hours because it is active by it will act by the modulation of the gene transcription. That's why it will take some hours. So that's why for immediate purpose we have to use beta agonist or other bronchodilator like anticholinergic. So the inhaled corticosteroids are used for long-term control like fluticasone, beclomethasone, budesonide, etc. Now these are the preparations. So we have multiple corticosteroids and glucocorticoid, mineralocorticoid, and their potency can be different, and we can remember this by remembering this chart. So it is actually nothing but that prednisolone 5 mg, that is equivalent to prednisone 4 mg. Okay, so this is the potency calculator. So prednisolone and is to prednisone, that is 5:4. Cortisol is to prednisolone 1:5. That means cortisol is 5 times more potent than the prednisolone. Methylprednisolone is actually, look here topically, prednisolone is 4:5. That means methylprednisolone 5 mg is equivalent to prednisolone 5 mg is equivalent to methylprednisolone 4 mg. It is 4:5. So potency for methylprednisolone is little bit higher than the prednisolone. So 4 mg methylprednisolone is 5 into 4, that is equal to 4 into 5 of methylprednisolone. That means, so for easy to remember, prednisolone 5 mg is equivalent to methylprednisolone 4 mg. Prednisolone 5 mg is equivalent to 1 mg of cortisol. Okay, sorry, 25 mg of cortisol. Potency of prednisolone is higher than the cortisol. Okay, and similarly betamethasone, dexamethasone, that is very highly potent. 30 mg, 30 is to dexamethasone 30 and betamethasone, suppose it is 40. So 5 mg. So how prednisolone is to dexamethasone? Suppose prednisolone is 5, dexamethasone is 30. That means dexamethasone is 6 times more potent than the prednisolone. That's why 5 milligram prednisolone is equivalent to 5 by 6 milligram of the dexamethasone, or we can say the reverse. 30 milligram prednisolone is actually equivalent to the 5 milligram of the dexamethasone. Okay, so as per the potency, dexamethasone is 6 times more potent than the prednisolone. That's why we can give 6 times less dose. Okay, so thus we can remember the dosing, because often steroids need to be interchanged, and while interchanging we have to maintain this balance. So guidelines for steroid therapy, largely empirical, neither specific nor curative except replacement therapy. So dose to be determined by the trial and error method and re-evaluate periodically. Careful patient assessment is mandatory. A single large dose is virtually without harmful effects and be reserved for the life-threatening conditions. A short course therapy is unlikely to be harmful. So when we are starting steroid therapy for anti-inflammatory purpose or immunosuppressive purpose, we try to make the duration as short as possible, preferably within 20 days. Ideally, it should be stopped within 2 weeks, but in some cases, disease is refractory, then you have to use long therapy. But if therapy is long, we have to reduce the steroid dose as much as possible. But in replacement therapy, when corticosteroid synthesis is decreased, as the patients of Addison's disease, then lifelong therapy is needed. We cannot give any other replacement. So abrupt withdrawal may be fatal. So if we are increasing the therapy beyond 20 days or beyond 3 weeks, then gradual withdrawal should be done, not abrupt withdrawal, because that will suppress the adrenal hypothalamic pituitary adrenal axis, and that patients will have precipitation of the adrenal insufficiency. So therapeutic use can be divided into diagnostic and replacement therapy. Diagnostic therapy is dexamethasone suppression test. We have discussed that while we are suspecting Cushing syndrome. So Cushing syndrome can be detected when patients having excess body fat, hypertension, there is moon phases, there is increased ergogenesis. So when we are suspecting Cushing syndrome, then we can confirm this by dexamethasone suppression test. That means dexamethasone is a potent corticosteroid that will, if it is given from outside, that will actually inhibit the ACTH release by feedback mechanism, and this decreased ACTH will actually decrease the endogenous steroid formation. Then thus it will be detected that ATM corticosteroid level will be low, ATM cortisol level will be low if we are giving dexamethasone. So thus we can detect the Cushing syndrome by giving dexamethasone. Also in replacement therapy in Addison's disease, when adrenal gland is dysfunctional, there is decreased synthesis of the corticosteroid, we have to give the corticosteroid by replacement therapy. And some life-saving indications like acute Addisonian crisis, anaphylactic shock, and some immunological disease like SLE, pemphigus vulgaris, status asthmaticus, that's anti-inflammatory, they are very commonly used. Some rheumatic disease, renal disorders, and also in some skin disease, malignancy, they are used as life-saving purpose, but this should be in low dose if it is thought to be continued for long term, or it can be high dose if it can be discontinued within few days. So this is feature of Addison's disease. There is hypoglycemia, there is postural hypotension, there is weight loss, there is GI disturbance, weakness, and there is bronze pigmentation of the skin because of the excess ACTH. So in Addison's disease, there is less corticosteroid synthesis. That's why there is negative feedback effect is less. That means there is more ACTH release, and this more ACTH release actually there is bronze pigmentation of the skin, and this is adrenal crisis. In severe cases, it can cause dehydration, vascular collapse. There is renal shutdown, decrease in serum sodium, and increase serum potassium. In rheumatic disease, steroids are life-saving for many. Actually, steroid synthesis was initiated in the rheumatic arthritis cases. So serious inflammatory disorders like SLE, polyarteritis nodosa, Wegener granulomatosis, Church-Strauss syndrome, giant cell arteritis, in all the cases, steroids are the drug of choice for initial control of the disease. And in nephrotic syndrome, that is a renal disorder, is very common in the pediatric age group. Patients will lose protein significantly, and ultimately there is hypovolemia and significant edema. Steroids are the drug of choice. And also it can be used in different skin diseases, pemphigus vulgaris, also in ophthalmologic conditions, inflammatory condition, it is a very good steroids are used topically. Acute lymphatic leukemia, lymphocytic leukemia and lymphoma, steroids are once again used because of their anti-lymphocytic action, because they induce lymphopenia. They are having also anti-inflammatory action, also having an immunosuppressant action. Additionally, they can stimulate the erythropoietin release, and that's why they can be used in treatment of the malignancy like lymphocytic leukemia and lymphoma. So that is the advantage of steroid, that in CNS it can cause some euphoria. So in malignancies, often patient's mood is low. Steroids can elevate their mood to some extent. And also we have mentioned that corticosteroids are helpful in the prevention of the graft rejection. That's why during transplantation, before transplantation, and also after transplantation, steroid cover is necessary so that patient's graft is not rejected, recipient does not reject the donor's graft. Okay, so organ transplantation becomes successful. Autoimmune hemolytic anemia, sarcoidosis, thrombocytopenia, these are the other uses. Spinal cord injury, when there is traumatic spinal cord injury or metastatic spinal cord disease, then corticosteroids are the life-saving drugs. And also there is doubtful role in shock and severe edema. So what are the uses? So these are the uses. So multiple use, actually, remember one by one, at least from the group. Allergic reactions like asthma, contact dermatitis, allergic rhinitis, collagen vascular disease, that means rheumatic disease. These are the major uses. Giant cell arteritis, systemic lupus erythematosus, SLE, polymyositis, rheumatoid arthritis, temporal arteritis, etc. In eye disease like acute uveitis, choroiditis, optic neuritis, gastrointestinal disease, that means the inflammatory bowel disease like ulcerative colitis, Crohn's disease. Hematological disorders like lymphocytic leukemia, multiple myeloma, and autoimmune hemolytic anemia, these are used. Systemic inflammation like ARDS, and also in severe infections like sepsis with shock. In septic shock, corticosteroids are sometimes used to control the inflammation. So gram-negative septicemia is optionally helpful to suppress the excessive inflammation. So these are the uses of corticosteroids which are non-repressive, non-endocrine use. So often question asked, discuss the non-endocrine use of the corticosteroids. So you have to answer this: allergic reaction, collagen vascular disease, gastrointestinal disease, hematologic, systemic inflammation and infection. And endocrine use means additional disease, as well as there is a disease called congenital adrenal hyperplasia, CAH. They are also corticosteroids are used as replacement therapy. Also inflammation both in joints like arthritis, bursitis, neurological disorder like severe edema, as well as spinal cord injury, organ transplant to prevent rejection, pulmonary disease. So corticosteroid help in the maturation of the lung of the neonates. So often when there is chance of preterm labor, baby's lung is not matured, corticosteroid like betamethasone is used, especially in pregnancy before 34 weeks. So because corticosteroid has been shown to increase the surfactant production of the lungs, so they help in the lung maturation. So when there is preterm delivery, the corticosteroid betamethasone is routinely used to mature the fetal lung. Nephrotic syndrome, it is used. Skin disease like atopic dermatitis, lichen simplex, pemphigus. Thyroid disease like malignant exophthalmos, that means when there is significant thyroid eye disease. So eye disease in thyroid is very common, especially in the hyperthyroid cases. So exophthalmos means when eyeball bulges out of the eyelid, that is called exophthalmos. That's we use corticosteroid. Also in miscellaneous like hypercalcemia, malignancy, mountain sickness, it can be used. Okay, so there are multiple uses of corticosteroids, but we have to use it very judiciously, because long-term use is often going to have some side effects, and that can be prevented if we can use it for short term, or that can be prevented even if we are using long term. Don't stop its use abruptly, because that will actually precipitate the symptom of the disease for which it was used. So two types of adverse effects: due to sudden withdrawal and due to supraphysiological dose. So steroid withdrawal will precipitate acute adrenal insufficiency, because when we are using corticosteroid for a long time, there is adaptation in the HPA axis, and if it is discontinued suddenly, there is corticosteroid production by the adrenal cortex is not satisfactory. That's why there is sudden drop in the corticosteroid level, that is called acute adrenal insufficiency, and that is manifested as malaise, arthralgia. Also there are some side effects like scleroderma cerebri, like there is increased intracranial pressure with rapid edema. And now these are the chronic use, effect of the chronic use. What are the effects? There can be, of course, there is development of the Cushing syndrome, excess corticosteroid. there is fat redistribution, there is Cushing syndrome. Hypertension, electrolyte abnormalities, mainly there is excess sodium and decreased potassium. Opposite of Parkinson's disease, Addison's disease, there is hyponatremia and hyperkalemia. In Cushing's disease, there is Cushing syndrome, there is sodium is increased, potassium is less. There can be hyperglycemia, glycosuria. There is immunosuppression, often it is used for immunological disease, but in normal patients, it can cause normal immune status. That can actually suppress the immune status. There is chance of infection. So supra-infection means when patients were normal, but there is increased chance of infection due to this immunosuppression induced by the corticosteroid. Osteoporosis, avascular necrosis of the femur neck, that is common. Also, there can be spontaneous fracture. So because of the osteoporosis, because of the calcium excretion, also decreased absorption of the calcium, also increased osteoclast activity, there is osteoporosis. There is myopathy, there is psychosis, and also in eye there is chance of glaucoma formation, also cataract formation. So these are the adverse effects. So remember, hypertension, hyperglycemia, chance of infection, osteoporosis, psychosis, glaucoma, and also peptic ulcer. Peptic ulcer is also caused by the corticosteroid, because corticosteroid also decreases the actinic acid production, and as well as there is decreased prostaglandin production, which is actually helpful in the maintaining the integrity of the gastric mucosal cell. If prostaglandin production is less, then there is chance of gastric ulcer. So steroid toxicity also produces gastric ulcer. So this is the manifestation of the Cushing syndrome. There is hyperglycemia, CNS irritability, there is thin extremity, and there is moon faces buffalo hump. So there is fat redistribution. There is susceptibility to infection. In male, there can be gynecomastia, there is osteoporosis, there is buoys and petechiae. Often there is the skin becomes thin and capillary becomes fragile, and that's why there is some buoys over the skin. There is purple stria, there is thin skin, and in female there can be amenorrhea and hirsutism. Okay, so they are the manifestation of the Cushing syndrome. Adverse reaction continued, peptic ulcer, growth arrest, acne, hirsutism. So this is actually problematic in the female. Hirsutism means excess hair growth, facial hair growth in the female. And in topical, there can be thinning of the skin. So corticosteroid cream should not be applied for long term, because there is loss of skin collagen, there is thinning of the skin. In inhalation, if it is used in high doses for long term, that can cause hoarseness of the voice. Especially happens when after taking inhaler, patients do not rinse their mouth properly. Then there is chance of this deposition of the corticosteroid in the oropharynx, that can cause hoarseness of the voice, and rarely it can cause cleft palate, alter neuronal development in the fetus, and there can be, very importantly, deactivation of the tuberculosis. So often tuberculosis patients, that their symptoms are suppressed, but corticosteroid actually unmasks their symptoms, because corticosteroid help in the, as due to their immunosuppressive action, they unmask the tuberculosis symptom, or that's why it can cause reactivation of the tuberculosis. So these are the corticosteroid actions. We have mentioned their actions on the as immunological agents, as immunosuppressive agent, and replacement agent. But there are multiple adverse effects. And remember, these should be stopped gradually. And it has been found that prednisolone 7.5 milligram per day, if it can be continued without significant adverse effect, but if we think about stopping, then also it should be stopped very slow, and if possible we have to use other drugs, immunosuppressive drugs, like we have some immunosuppressive drugs like azathioprine for rheumatic arthritis, we have methotrexate, we have infliximab, so other immunological diseases. So if this can be used, then their adverse effect is little bit less than this corticosteroid. So, but sometimes patients are refractory to other treatment, then corticosteroid therapy is essential. So what we can do, so for Addison's disease we have to supplement corticosteroid. For pituitary disease also we have to supplement corticosteroid like hydrocortisone. But what do when corticosteroid is in excess? So there are some antagonistic adrenocortical agents like metylapone, they inhibit the 11-hydroxylation, so that interferes with the corticosteroid and corticosteroid synthesis, and they treat so metylapone is a synthetic inhibitor of the glucocorticoid antagonist. Aminoglutamide, another agent that is blocks the conversion of the cholesterol to pregnenolone and causes a reduction in the synthesis of all hormonally active steroids. So they can be used in breast cancer and Cushing syndrome due to adrenocortical cancer, 250 mg every 6 hours. So they enhance the metabolism of the dexamethasone. Okay, so they block the conversion of the cholesterol to pregnenolone and also reduction in the of the all hormonally active steroids. Aminoglutathionine is another option, also trilostane another option, and mineralocorticoid antagonists. So these are the glucocorticoid antagonists, methylidapone, aminoglutathionine, trilostane, and these are the mineralocorticoid antagonists. That mineralocorticoid, that means these agents which are maintaining the fluid water and salt balance. So fludrocortisone we use in postural hypotension, but that is in the when mineralocorticoid are deficient. But in mineralocorticoid excess we use spironolactone. So that is an aldosterone antagonist. We all know spironolactone we have discussed in heart failure, because aldosterone are excess in the production in the heart failure cases. Aldosterone will cause remodeling cardiac fibrosis as well as heart and retention. So in heart failure, spironolactone is a very good drug because that will decrease the action of this aldosterone. As well as we have eplerenone, because eplerenone is used only when there is gynecomastia due to spironolactone. Also you have drospirenone, that is a progestin in a new oral contraceptive that antagonizes the effect of aldosterone. So these are the mineralocorticoid antagonists and which can be used in treatment of the mineralocorticoid excess. Okay. So if there is any question you can ask me. This is the corticosteroid. So remember their effect on the metabolism, remember their effect on the fetal lung. It is very commonly asked question, and remember their effect on the immunological disease and also in different and inflammatory disease. Okay, and remember their adverse effects. Remember their contraindications. So what are the contraindications? So the contraindications is peptic ulcer, diabetes mellitus, hypertension. All the adverse effects actually are contraindications. So peptic ulcer, diabetes mellitus, hypertension, severe infection. When the infection is and there is some especially fungal infection, corticosteroid is absolutely no. And osteoporosis, psychosis, epilepsy, heart failure, renal failure, there corticosteroid should not be given. And remember that those should be as low as possible, but if it is used for short term, then high dose can be used, that will cause no harm. But in chronic use, we should use minimum dose. And we can prevent the suppression of the HPA axis by using shorter acting steroids and use steroids for the shortest period of the time. Give the entire daily dose at one time in the morning and switch to alternative therapy if the condition does not deteriorate on the off day. So often during tapering therapy, we use suppose we advise patient take steroid on one day, do not take on the other day. And it can be if it is successful, that means in the off day if there is no symptom, then we can gradually increase the gap of this steroid. Suppose in we are giving 1 day therapy and making 2 days off therapy. Like that, we can gradually discontinue the steroid. And remember the replacement effect. We are using the acute adrenal insufficiency. We use hydrocortisone or dexamethasone. Also, chronic adrenal insufficiency is Addison's disease and congenital adrenal hyperplasia. That is a familial disorder due to deficiency of the steroidogenic enzyme like 21-hydroxylase, and there is compensated increase in the ACTH secretion causing adrenocortical hypertrophy. So enzyme deficiency being only partial in most cases. If the deficiency is severe, salt wasting also occurs, and treatment is by giving hydrocortisone in divided doses, and if salt wasting is there is we have to give fludrocortisone. So replacement, so endocrine use of the adrenal corticosteroid are acute adrenal insufficiency, chronic adrenal insufficiency, that is called Addison's disease, as well as congenital adrenal hyperplasia. But rest others are non-endocrine cause, and that's a huge list. Okay. So remember this corticosteroid and also mechanism of action. They cause alteration of the modulation of the gene. So they increase the production, transcription of the inflammatory genes, anti-inflammatory genes, and decrease transcription of some pro-inflammatory genes. That's why there is help in the inflammatory disease, mostly asthma and rheumatic disease. Okay.